thanks, Kate, and thanks to you all for attending today. I'm going to present a case too as we go through the next 15 minutes or so, just as a template to highlight some of the principles of taking care of people with HIV as they age. It is certainly true that it's been debated over the past 4 or 5 years if having long-standing HIV infection actually accelerates the aging process. And I think what's come about is that that's kind of the wrong question to ask, or wrong postulate to put forward. What HIV certainly does is provide a very unwanted source of inflammation over a period of decades, even when the virus is well controlled. So as a chronic inflammatory condition, it tends to worsen the natural sequela of the aging process. So in a way, it kind of accelerates certain aging phenomena, but it doesn't necessarily shorten people's lives as far as we know yet. It produces a cornucopia of kind of co-traveling conditions that may be a result of long-standing HIV infection or of long-term therapy for HIV, or both, which seems to make occurrences that naturally come with aging occur a little bit earlier in people's lifetimes. So let me illustrate that with a case. Go on to the next slide. I do that, huh? Okay. Let me tell you about a 78-year-old man who'd been HIV positive for at least a quarter of a century, probably quite a bit, who'd recently, over the past weeks to months, manifested weight loss and an insidious cognitive impairment, which many onlookers had noted over the past few years, but many said, oh, it's been a year or so. And some people said, well, maybe the past year and a half. Primarily manifested in word-finding deficits. This particular guy was quite the talker, and he was having trouble getting through sentences, having trouble finding the words he needed to express himself, which, as many of us in geriatrics know, is a common syndrome that emerges with natural aging, but seems to be more prominent in people with early memory. His physical exam was otherwise fairly unremarkable. He's outwardly appearing fairly healthy for being 78 years old, maybe a little bit on the frail side, but not too bad. So his main problem was this memory loss and worry about his daily functioning. His lab tests weren't particularly unremarkable. He was a little bit anemic with a hematocrit of 30, a little bit azotemic with a creatinine of 2, which all of us geriatricians know would produce a creatinine clearance in the neighborhood of 35 or 40 in a 78-year-old man. His T-cell count, or CD4 count, was 82. A healthy 78-year-old who is not HIV positive should have a CD4 count of several hundred at least, if not over 500. His viral load was 280,000. That's HIV viral load. Of course, if he had been on good therapy, that should be undetectable. And given his memory loss, another battery of tests was sent: B12, TSH, number of other things, folate. The rest of his labs were unremarkable, and his CAT scan was not different from other 78-year-olds. So no big help from the CAT scan. So actually he was in a kind of assisted living apartment building already, but he was moved to a memory unit in this assisted living facility and started on HIV medicine, which is, many of you know, is usually a combination of therapies, usually at least 3 agents, if not more. And a simple regimen these days, integrase inhibitor, often dolutegravir, and dual nucleoside reverse transcriptase inhibitors. So 1 pill once a day, pretty easy to take. Over the course of the next months to a year or so, there was a little bit improvement in weight. It seemed like he was a little bit steadier on his feet. His word finding maybe got a little bit better, but maybe it was because he was in this protected environment, speaking to familiar people, and was having less trouble with word finding difficulty. And at 1 year, his CD4 count was 152. His viral load was undetectable. That latter is something we shoot for with therapy. But usually, if this person was 38 years old, his CD4 count should have gone from 82 to 352. We'd be looking for a much more robust response in his T cell count, and he had not achieved that at 1 year out. That's because all of our immune systems decline with age, and that starts in your 30s and 40s. Most people undergo thymic general deterioration, and our T cells, particularly those T cells that are naive, that can respond to a new challenge, go down as we age. That happens to everybody, HIV positive or not. But HIV attacks those very T cells and involutes into the genes and kills preferentially the naive CD4 and CD8 cells. So there's reduced proliferation, there's increased T cell activation, which means there's even less naive T cells, and increased inflammatory markers. So all of those things happen to everybody as they age, and they are markedly accelerated in the setting of HIV infection, because that's the focus of the infection. That's where the HIV viral particles go, is to these very T cells that are instrumental in our cellular immunity, everybody's cellular immunity. So, it probably won't, well, this might surprise you. Here's a graph of how viral load suppression goes with age. So here's a shocker. That top line of excellent viral load suppression is actually older people with HIV. So older individuals with HIV infection, when started on medicine, actually have better viral load suppression than younger people. Those other lines below that top line are the younger cohorts. So better viral load suppression, but they come up last in CD4 rise. So they're better at suppressing their viral load in the bloodstream, but their CD4 counts do not rise as well as in younger people. And people wonder, well, why might that be? Well, probably because older people are better at taking their medicine than younger people. That could be one reason. And maybe it's easier to suppress a viral load than it is to actually recover your immunity when you're aging and have immunosenescence. So the good news there is that viral load's suppressed. Bad news is it doesn't do older people as much good to suppress their viral load. Just like in our case, where his numbers got better, but he wasn't largely better. He was still on the memory unit. In a 78-year-old with dementing illness, one might wonder, well, is this from his HIV, or is this from Alzheimer's disease, or what? And the answer to that question is yes. The normal etiology of memory loss in a 78-year-old would be Alzheimer's disease, right? If 2/3 of the people that walk into the Memory, Brain, and Wellness Center here, who are in this age group, will have Alzheimer's disease before, you can count on that before even doing a workup on them, because that's the most common etiology. But in people who have even more advanced age, 80s and 90-year-olds, usually it's multifactorial. It's Alzheimer's disease plus a little cerebrovascular disease, or plus a little history of alcoholism, or plus maybe a head trauma in their youth, or plus maybe HIV. In this particular case I presented to you, it may have something to do with his HIV, and may have something to do with the most likely cause of Alzheimer's disease, and maybe a little of both. What a geriatrician does is say, okay, I'm going to try to treat you and improve it no matter what the cause is. And so that's where we tackle it. So People with long-standing HIV may be a little bit more frail than similarly aged people. They might have more sensory impairment, more nutritional deficiency. All of those things play into making dementia symptomatology a little bit worse. So dementia is a syndrome. It's a common geriatric syndrome, right? And in geriatrics, we're not very good at using Occam's razor to find one cause for anything. We tend to think syndromically. So that's how we'd think about this fellow's dementia. Yes, we're going to treat his HIV. Yes, we're going to see if there's something we can do about his sensory impairment, his frailty. See if we can make things good. HIV infection in general, and in older individuals in particular, is actually not the leading cause of death anymore among HIV-positive people. In fact, nearly at least 2/3 of death certificates of people who have long-standing HIV infection do not even list that as one of the causes. It might be another condition not linked to cause of death, but usually it's things like cardiovascular disease, cancers, liver disease, advanced liver disease, advanced pulmonary disease, alcohol or drug abuse. HIV's back in there, but often that's the least of the problems. It's usually some other significant condition. So in the modern age, the cause of death in people with HIV infections, often these other things, which may or may not be related to the HIV, peripherally or directly. And there's increasing comorbidity among older people with HIV. Here's a chart of the prevalence of diabetes in people infected with HIV in the dark bars and non-HIV in these age cohorts. And you can see that diabetes is far more common in HIV-infected persons, usually having to do with antiretroviral medication. So it's, in a way, it's a side effect of antiretroviral medication that people develop diabetic syndrome. In people who are aging with HIV infection, a lot of things we worry about are the same things we worry about in anybody with multiple diseases in their 80s and 90s. Loss of bone and muscle mass, sarcopenia, frailty, decreases in GFR like our patient had, memory loss or incipient memory loss. We know about immunosenescence, and so a common thing to counsel our patients in senior care clinic around the time of flu shots is, well, it might work and it might not. Don't be surprised if it doesn't work as well. We still want you to get your flu shot. Frailty, multimorbidity, and polypharmacy. That pertains to anybody in their 70s and 80s, HIV infected in particular. So here's the eras of the HIV epidemic winding down. I was fortunate to practice through all three of these eras. In the early era, as Kate mentioned, I participated in care when HIV was basically a life-ending condition. And palliative care was the main functionality of an HIV provider. Then in the 90s, particularly the late 90s and the subsequent decade, was the antiretroviral era, a period of great hope that HIV was a condition that was complicated, but could be controlled like diabetes can be controlled. And that people who were very good at manipulating antiretroviral regimens became HIV specialists and made HIV a condition that was largely a drug juggling exercise for people who were generally pretty healthy. But now we've entered the chronic disease era, and people, at this point, the majority of people in the U.S. with HIV are over 50 years of age. And that will continue to rise over time. So we'll be dealing in the subsequent decades with HIV and the effects of aging, with comorbidities and those kinds of things going forward. As HIV becomes more and more controllable and becomes more and more an uncommon condition, the wave of people as the epidemic advances will actually fade in the second half of this century. And that will be a whole new era where HIV is a relatively uncommon condition and controlled, and the worry will be less difficult. But for the next 2 decades, we'll be dealing with older people with HIV, and all HIV providers will be presented with these kinds of challenges. So let me stop there. We can entertain some questions and or go on to Anshu's case.